All right. Hi, everyone. Welcome. We are a smidgen early, but you are joining the Laser and Skin Surgery Center webinar with Dr. Ariel Abraham on psoriasis. And we are going to be getting going in a few minutes. But for now, I see a lot of you joining, so welcome. I am going to teach you a little bit about how to use the platform. If you are joining us on Facebook, some of the things that I'm mentioning are on Zoom. So if you're able to join on that platform, it might be easier. But on the bottom of the screen, there should be a Q&A feature and a chat feature. You can use the chat feature if you have any questions for me or you're having any technical difficulties. Otherwise, if you have questions that you would like Dr. Abraham to answer, maybe you already have some questions about psoriasis, or while he's speaking something comes up, or at the end, you can populate in that field and he's going to try and answer as many as he can. So again, welcome. You are joining the Laser Skin Surgery Center of New York webinar on psoriasis, which is going to be an introduction to the treatment of a common skin condition. And today we're here with Dr. Ariel Abraham, who's one of our newest physicians to join the group. So I'm really excited for many of you all to meet him. He is primarily or exclusively seeing patients in our Southampton location. So if some of you are tuning in and you're used to coming to our Manhattan office, that may have been also why you haven't seen him yet. All right, so I think we should go ahead and get started. I do still see some people joining, and I will just let you guys know this will be recorded. So you can always tune back in and re-listen to any portions that you unfortunately missed. So without further ado, I am excited to introduce Dr. Abraham. Hi, Dr. Abraham.
Hello.
So Dr. Abraham, like I said, is one of our newest physicians to join the center. He hails from Maryland, and he went to the University of Maryland for his undergrad. He did his MD and PhD at Stony Brook in molecular cellular pharmacology. He was a chief resident while he was at Stony Brook. But actually, even before he went to medical school, he did a few fellowships at the National Cancer Institute and the NIH, and he worked there for a few years, also at the Howard Hughes. So he has done a lot of research, and he definitely has a vast background to help him understand a lot of these skin conditions, and specifically psoriasis that he's going to be speaking about today. He was in private practice at first, and then now very proud to have him join the Laser Skin Surgery Center. At the Laser and Skin Surgery Center, he treats exclusively medical dermatology and skin cancer. So although many of you know us for our cosmetic treatments like lasers and injectables and plastic surgery, Dr. Abraham does all of the medical dermatology and skin cancer. So that's things like eczema and psoriasis and acne and even lumps, bumps, warts, moles, anything like that. And of course, cancer checks. And also, I want to make sure you guys all know he sees kids, as does our entire practice. So, and speaking of kids, he actually has a few of his own. He has 3 kids, two-year-old twins, which sounds very, I'm very proud of him for being able to still be here today, and he has a 5-year-old son. So without further ado, thank you so much, Dr. Abraham, for joining us today.
Thank you. So thank you, and thank you for the warm welcome. Today I'm going to be talking a little bit about psoriasis. It's really just an introduction to the treatment of a very common skin condition. I'm in our Southampton location right now as we speak, and this is our address and our phone number if anyone needs to reach us. Okay. So in terms of psoriasis has many different faces. Psoriasis comes in many different forms. There is plaque psoriasis, which is sort of the prototypical version of psoriasis that you see. But there are many other types of psoriasis. Psoriasis can come as different forms of psoriasis, so that includes inverse psoriasis. You can get inverse psoriasis underneath your armpits, underneath the breasts, in the groin, in the crease of your buttocks. You can also get psoriasis on the palms and soles of your hands and feet. There are other versions of psoriasis as well. There's a type of psoriasis called gut-tape psoriasis, which causes basically drop-like forms of psoriasis that occur on the body. This is commonly seen in kids and adolescents and young adults who have recent strep infections. and get flares of guttate psoriasis. What's interesting about psoriasis is that sometimes there are other skin conditions that can sometimes mimic psoriasis. Sometimes psoriasis can be misdiagnosed and be called a rash of intertrigo that's underneath the breast or in the armpit or in the groin. It can be sometimes confused with another rash like eczema or nummular dermatitis, which causes sort of coin-shaped patches on your body, including on your arms and your legs. And sometimes people lump them together, eczema and psoriasis, as if they go together. But the truth is that they are two very, very different conditions. The reason that it's important is that psoriasis tends to do other things that eczema doesn't necessarily do, which leads us to our next point about psoriasis. Psoriasis can affect other things other than just your skin. So psoriasis can actually cause pitting of your nails and onycholysis and lifting of your nail plates that can cause nail dystrophy. So your nails can actually change in appearance as a result of psoriasis itself. And it's not just your nails that can change, it's also other things. Psoriasis and the inflammation that goes with it can also contribute to psoriatic arthritis that basically causes inflammation in your joints, which contributes to both stiffness and pain. So psoriasis is not just only about the skin, it's about the skin and the nails and the joints and other organ systems that can be affected by the psoriasis and the inflammation that goes along with it. There are many different variants of psoriasis, like I had just mentioned, but left untreated, things can progress and sometimes get worse. This is a version of psoriasis called pustular psoriasis, where things kind of progress and get out of hand. It's a more severe form of psoriasis that's not often seen, but can be seen in patients who have a severe flare. When psoriasis goes untreated to its latest stage, it can become very, very bad, in which patients become what's called erythrodermic, or full body red. That's a very rare form of psoriasis in which patients sometimes end up getting hospitalized for the psoriasis and are treated in the hospital to ensure that they get better and that they in fact have psoriasis and not something else, okay? So there are additional considerations to take into consideration with respect to psoriasis, okay? Psoriasis oftentimes flares up at the worst possible time. The known association with psoriasis has to do typically with stress. Stress tends to worsen psoriasis and contribute to psoriasis flares. The frequency of the flares can become debilitating. Some people have flares where they flare once a year, and that's the nature of their psoriasis, whereas other people are flaring on and off, and they flare once every 3 weeks, once every 4, 5, 6 weeks, and it becomes something that affects their quality of life. Also, the flares can change. You can have mild flares and that become more and more frequent, and then the severity of those flares change and become more and more severe. Additionally, the other consideration that's really important is whether or not the psoriasis that's flaring, whether or not it's actually responsive to treatment. Sometimes flares of psoriasis stop responding to topical medications or injection of steroids because the psoriasis and the nature of that disease progresses to the point that the steroids can't actually maintain the improvement of the actual condition. There are other things that also are factored into the equation. Some medications can actually worsen psoriasis itself, contribute to the increased severity and frequency of flares. There's a known and documented association with high blood pressure medication, ACE inhibitors, beta blockers, that sometimes contribute to flares of psoriasis and worsen psoriasis. There's also an association with seasonal fluctuation of psoriasis. A lot of times patients get significantly better during the summer months where it's warm and sunny, and they get sun exposure to their psoriasis plaques on their arms and their legs from wearing shorts and t-shirts, and the psoriasis gets much, much better during that time. And then the inverse happens, the opposite happens, where patients flare as they go into cooler weather. As July and August and September turn into October and November and December, the colder and colder weather progressively worsens the flares of psoriasis and patients get worse. Now, there's a workup that you can do to actually discern what you're dealing with. If there's any confusion about whether or not something is or is not psoriasis, if there's any debate about that, You can do a skin biopsy and ask a dermatopathologist about whether or not there's evidence of psoriasis in the skin, or whether or not what you're looking at is something else, like eczema or a drug rash or some other process that's in the skin, okay? When there is something conclusive, like a biopsy that shows psoriasis, you can introduce a workup, including blood work, to look for any evidence that would allow you to treat patients with biologic medications. And that's what we're going to talk about in a little bit. To do those biologic medications and get patients clear of psoriasis, you have to check several things. Some of those things include the status of a patient's tuberculosis, whether or not they've ever had it in their life, whether they've ever had hepatitis B or hepatitis C, and to check for their antibodies in their blood, and to do basic blood work, including a comprehensive metabolic panel and a complete blood count to check for basic blood work and blood chemistries. So there are many different treatment strategies in terms of psoriasis, okay? You can treat psoriasis with many different types of topical medications, and we'll go over that in a minute. There's also the possibility of treating psoriasis with light therapy, and that light therapy includes narrowband UVB light therapy. There's also systemic medications that can be used to treat psoriasis, and they're broken down into oral pills, which are not biologic medications, and biologic medications, which are injectable medications that can be used to treat psoriasis. So in terms of topical medications, so what are examples of topical medications that can be used? So topical medications that can be used include topical steroids. Those include pretty potent steroids like halobetasol, clobetasol, betamethasone, triamcinolone. The problem with these steroids is that they cannot be used indefinitely. If you use steroids indefinitely, you can atrophy the skin and thin out the skin and cause changes in the skin that are unhealthy and really not desired. Certainly you don't want that cosmetically, because atrophy of the skin is not cosmetically a nice appearance. So there are other medications that can be used that don't atrophy the skin. These medications include vitamin D analogs. Certain medications like Davonex or calcipotriene can be used in parallel with topical steroids to bring the psoriasis under control. There are other medications that can also be used, including topical retinoids. These are medications like tazarotene. Some people may recognize tazarotene as an acne medication. It's the medication that's actually in Fabior and Tazorac, which are acne medications. But tazarotene can actually be used for psoriasis patients to actually thin the plaque of psoriasis, so that the steroids can help penetrate the psoriatic plaques and thin out the plaques and get control of the psoriasis. There are also alternative medications that are safe for use in the armpit and the groin. There are a class of medications called calcineurin inhibitors, which are tacrolimus ointment that goes by the brand name Protopic, and pimecrolimus cream, which goes by the brand name Elidel cream. These are medications that are often used for atopic dermatitis and eczema in kids and adults, but they can also be used in patients who have psoriasis in sensitive areas, including the armpit, the groin, underneath the breast, and on the face. These are very effective medications and are safe to use. Finally, one strategy that you can use is also the combination of topical medications. So if you combine potent steroids like betamethasone and Davonex, calcipotriene, you will get Enstellar foam. That is a very effective medication. Combinations of tazarotene and halobetasol go by the brand name Duobri. And that's also another FDA-approved medication for psoriasis that's effective. So in terms of treatment strategies, not everyone will respond to these topical steroids. Some people will use these topical steroids and not get cleared, but they may not be excellent candidates for oral pills or injectable biological medications. And those patients may be excellent candidates for a form of light therapy called narrowband UVB. There are pros and cons to using narrowband UVB. Narrowband UVB is often started 3 times a week. It's administered in increasing doses. We have access to narrowband UVB at our Spring Street address. But there are questions about whether or not it's the best thing to do in light of the fact that there is the possibility of increasing doses of the light therapy can sometimes lead to certain problems with the narrowband UVB, including sometimes redness and burning. And there's a question also about of affordability, about whether or not people can afford copays and the like when it comes to narrowband UVB 3 times a week. The alternative is the possibility of actually introducing oral pills to bring the psoriasis under control, or to inject biologic medications. So for non-biologic medications, including oral pills, there's a medication called acitretin. So this medication is approved for psoriasis and can be used in 25 to 50 milligram doses once daily. The problem with acitretin is that even though it works for psoriasis, it can have some side effects that some people really don't like. For example, acitretin can affect your hair. It can sometimes cause hair to fall out. It can also affect blood cholesterol and triglyceride levels. It can affect liver enzymes, and for sure, it is not compatible with drinking alcohol. So patients who are on acitretin really should not drink alcohol. That's a little bit of a complicated issue, because that medication can be converted to another medication that can stay in your system for a long time as a result of drinking alcohol. So it's not compatible with it. The alternative is to use either methotrexate or cyclosporin. Methotrexate can be used for psoriasis. It's usually 10 to 25 milligrams once weekly. It can be associated with kidney or liver dysfunction. Cyclosporin is actually very effective for the treatment of psoriasis. I've had many patients who I personally put on cyclosporin, including those who had erythrodermic psoriasis, who I brought under control with cyclosporin. It's not supposed to exceed 4 milligrams per kilogram per day, but it can also be associated with kidney and liver dysfunction. The problem with cyclosporin is that you can't sort of stay on it forever. It's a medication that we sometimes use to kind of bridge patients to another medication, like a biologic medication. But one of the downside problems with cyclosporin is that there is a known increased risk of developing lymphomas and other cancers, including skin cancers, with cyclosporin, that we sort of shy away from its use for long periods of time. Sometimes we use it for short periods of time to kind of get a handle on things, but there are downsides to using cyclosporin for longer periods. So in terms of treatment strategies involving biologic medications, now these are the medications that I was sort of alluding to earlier. These are the medications that are injected, that have been around for the last several years. And we're going to discuss different core categories of these medications. So the first one that we're going to sort of address in terms of biologic medications are anti-tumor necrosis factor medications. These medications have been around for some time. You may recognize their names because they include Remicade, Enbrel, and Humira. Humira is a very, very popular, very effective medication that has been around for many, many years and is FDA approved for the treatment of plaque psoriasis. But it can also be used to treat psoriatic arthritis, rheumatoid arthritis, Crohn's disease, ulcerative colitis, and another skin condition called hidradenitis suppurativa, in which patients get lesions, draining lesions that occur in their armpits and in their groin. Humira is a safe and effective medication and has been around for many, many years and is used quite successfully for psoriasis. Humira, well, I'll just go back. Humira is injected 80 milligrams at the first part of the loading dose of the medication, and then you inject 40 milligrams of that medication once every 2 weeks, and that helps bring the psoriasis under control. An alternative medication to Humira that also works very, very well, and that is safe and effective, is a medication called Stelara, or ustekinumab. Okay, it's been around for many, many years, and I have used it on many, many patients who are very, very pleased with this medication. It's an interleukin 12/23 blocker, and what's unique about it is that it's slightly different from Humira in the sense that there's weight-based dosing. So if you weigh less than 100 kilograms with the medication, you're injected with 45 milligrams of the medication. If you weigh more than 100 kilograms, you're injected with 90 milligrams. And it's actually a really, really convenient medication, because once you get injected once or twice with the loading dose, you only inject once every 12 weeks, which is really, really, really convenient. And a lot of patients get clear and are very happy with the medication. I have not run into many side effects with Stelara. It's safe and effective and is FDA approved for both psoriasis, but as well as psoriatic arthritis and Crohn's and ulcerative colitis. So it's protective for a patient's gut, which is an added benefit in terms of the medication. The alternative is to use a newer medication and a newer class of medication called interleukin-17 blockers. These are newer medications that have been around for the last few years. This particular medication is a medication called Cosentyx. Cosentyx is made by Novartis. It's FDA approved for the treatment of plaque psoriasis, scalp psoriasis, and also active psoriatic arthritis. The medication is safe and effective. I've put many, many patients on Cosentyx who are extremely, extremely happy with being clear. And they are also extremely happy with the improvement of their psoriatic arthritis, which many patients didn't even realize they had. I have several patients who went on Cosentyx who literally stopped feeling stiff and stopped feeling painful joints, both in their knees and in their shoulders and in their elbows and in their back. And some people swear by the medication. The only issue with Cosentyx is that sometimes it can worsen underlying Crohn's disease or inflammatory bowel disease. And you have to be very, very careful about choosing the right patient to go on the medication and ensure that they don't have any diagnosis or any symptoms that would suggest Crohn's disease before going on the medication. The alternative within this class of medication is another interleukin-17 blocker called Taltz. It's FDA approved for psoriasis and also can be used to treat psoriatic arthritis. But like Cosentyx, it can also worsen Crohn's disease, ulcerative colitis, and inflammatory bowel disease. It is a tremendously effective medication. I've injected many patients with Taltz, and it works very well and is very rapid. Some of the most rapid responses that I've gotten with biologic medications, including rapid improvement, include Cosentyx and Taltz. Finally, there's a medication within this interleukin-17 class of medications called Siliq. Siliq is a medication that also goes by the name brodalumab. It's FDA approved for psoriasis. Its history is just a little bit more complicated because there is a little bit of a black box warning on the medication associated with suicidality and depression. And so there is a little bit of a concern with respect to that medication, the use of that medication, and it's definitely not supposed to be used in any patients who have a history of Crohn's disease. It's an active contraindication to using Siliq. Last but not least, I want to just sort of focus on a newer class of medications that came out in the last few years. There is a newer class of medications called interleukin-23 blockers. One of the newer ones that came out the last several years was a medication called Tremfya. Tremfya is a very safe and very effective medication that I've put many patients on. It's FDA approved for plaque psoriasis and psoriatic arthritis. It's convenient. You inject it once at week 0 and week 4, and then you inject once every 8 weeks thereafter. I've never had any patient who had any complaints about any type of worsening GI issues with Tremfya. So I've never had any patients with worsening Crohn's disease or colitis or any type of inflammatory bowel disease that got worse on Tremfya. The last medication and the most recent medication that came out is a medication called Skyrizi or risankizumab. This medication is actually from AbbVie, which is the company that makes Humira. So it's the same company that has a proven track record with respect to biologic medications for psoriasis. It's also an interleukin-23 blocker that's FDA approved for plaque psoriasis. It's very convenient in terms of injections. You inject 150 milligrams of this medication at weeks 0 and 4, and then once every 12 weeks thereafter. That's incredibly convenient because you're only injecting it once every 3 months. So that's a total of 4 injections a year. I've had several patients who have gone on this medication and have done extremely well. A handful of patients who failed other medications and other biologics were switched to Skyrizi and completely cleared on this medication. One patient, actually, I injected him with one dose, and he was completely clear within 4 weeks. Within 4 weeks, he was completely clear after one injection, which is a remarkable improvement. The safety profile of the medication is excellent. The clinical trial data definitely supports that, and there are no contraindications to its use, including none related to Crohn's disease or inflammatory bowel disease. It's a highly effective, fast onset medication. The data actually supports its use, and the data actually is very, very good for it. In the clinical trial data, it showed that about 8 out of 10 patients get about 90% clear on Skyrizi, and that there are 6 out of 10 patients who get about 100% clear on Skyrizi. So we now have medications that are getting a significant number of patients either 90 or 100% clear using these biological injectable medications. So what I found is that a lot of these patients who go on Skyrizi oftentimes don't have to continue using topical steroids or oral pills or narrowband UVB or any of these other treatments, because the biologic medications are so sophisticated that they bring the disease state completely under control and patients get completely clear. So some final considerations about psoriasis, about the use of biologic medications. There are numerous treatment options. Not everybody wants to go on oral pills. Not everybody wants to be injected with biologics. There are topical medications, both steroidal and non-steroidal. There's light therapy that can be done. There are oral pills that can be taken, and there are biologic medications that can be injected. But the take-home point here is that the biologic medications are safe, they're effective, they're rapid in their onset, but you have to be careful and you have to tailor it to the patient's need based on their personal medical history, specifically whether or not the patient has a history of any type of gastrointestinal disease, any history of Crohn's or colitis or inflammatory bowel disease, whether they have any history of cancer, whether or not they have any history of infections like tuberculosis or hepatitis B or C or otherwise. These are really important considerations to take before actually starting a patient on a biologic medication. That is my talk, and I'm happy to take any questions or address any concerns or anything like that, and I'll hand it over to you guys.
Thank you so much, Dr. Abraham. That was very informative. I'm sure everyone else would agree. We do have a couple comments coming in, but now for those of you that maybe didn't want to ask questions yet or weren't ready, at the bottom of the screen there's a Q&A function. I'd love you to add any questions you have there right now, so Dr. Abraham can go ahead and start answering them. And before we get to that, if someone wants to take a screenshot of the screen that's up right now so you have the contact information, so in case you would like to make an appointment. So I'll leave that up for another second, and then I'm going to take that down, if you don't mind, Dr. Abraham, so we can see you a little bit bigger while you answer all these questions. Okay, great. So here is the first question. Can you comment on Otezla? I hope I said that.
Otezla. Okay.
Otezla, sorry.
So Otezla is a safe and effective medication for the treatment of psoriasis. I have put many patients on Otezla. It does have some side effects. Otezla from time to time can be associated with gastrointestinal side effects. Some patients complain of abdominal pain, nausea, vomiting. Sometimes they get diarrhea. I found that that's kind of few and far between. There are a lot of patients who take the medication, and then once they've been on it for a little while, sometimes they don't complain at all of any type of gastrointestinal side effects. The medication does help, but it's not as powerful as the injectable biologic medications. It is a safe and effective medication, and a lot of patients who want to be on an oral pill but don't want to be on a biologic medication, but don't want to be on a medication that has the side effects of methotrexate and cyclosporin, actually opt to go on to Otezla. So there is a role for Otezla, So the answer is yes, it's definitely out there. It definitely can be used. It's definitely safe and effective. It just depends on the patient and whether or not they're the right candidate for Otezla.
Great. So you may have commented on this, but someone's asking, does it cause hair loss?
Otezla?
Yeah.
I've put many patients on Otezla, and to my recollection, I cannot recall a single patient who told me they lost hair because of Otezla. The hair loss association is often with acitretin or soriatane. That's actually something that I've seen many times. And if you look it up, there's actually a known association with that. Sometimes 50 to 75% of patients can lose hair with acitretin, but not with Otezla. That's not what I've seen typically.
Okay, great. All right. Here's another question. It's a little more detailed. So this person says, I have eczema and have been treated through the years. I'm now getting intermittently hives one day on the arm, then on the other, never at the same time. Same with my
Sure.
groin, first one side and then the other. I have dry skin treated with CeraVe soap and cream. Eczema will come at intervals with itching. I've tried triamcinolone cream as an
Yep.
adult and have seemed to develop more eczema and hives. Any suggestions? I know we can't give too much personal medical advice on here, but if there's anything generic you can say.
There's nothing wrong or harmful with moisturizing the skin with CeraVe moisturizing cream. It's actually a fantastic product, and I recommend it to tons of my patients. And so I have a lot of patients who are moisturizing with CeraVe. The only issue there is that it sounds like there's more than one thing going on. So if there's eczema and then there's intermittent hives, that's another situation that needs to potentially be seen in real time. So the hives are what are called urticaria, and you can get different types of urticaria. You can get acute urticaria, you can get chronic urticaria, and it really depends what's precipitating the problem. But that should be seen in the office to further evaluate it, potentially consider biopsies and other workup to figure out what's going on. But there are treatments for all of those things. Topical steroids can be used for eczema. There are many medications, including oral antihistamines and other injectable medications that can be used for urticaria. But you have to prove that that's what's going on, rather than assume that that's what it is. But it should be evaluated to discern that it's actually really urticaria and eczema, so that you can actually treat it correctly.
Okay, great. So I guess that leads me to have a little question. So if someone is dealing with psoriasis, do they need to try and make their appointment when they're having an outbreak, so there's lesions to be seen?
So psoriasis waxes and wanes. There are many patients who come in who tell me like they'll have a skin check in the summer months, and they'll tell me I have psoriasis that's on my legs, and it's not really terribly noticeable right now, but come November, December, January, I'm going to be flaring, and it's going to be fairly bad. So the answer here is that there's never anything wrong with establishing care before things get bad. So if you want to come in and evaluate what you have, even if it's just 10% of what you typically have with a flare that occurs during the winter, it's worth seeing someone now, so that you have some sort of medication or game plan for treatment, so that also when things worsen, you have an established also relationship with that person, so that you can call up and get in really quickly and say, look, it's December or January, I'm flaring really badly, I need to be seen. It makes sense to actually then be seen immediately as well. So my advice is that try and establish care to address things now, and then down the road when things flare up, the door is always open for you to come back when things are flaring. But you should always try and get in. Even if there's only 10% psoriasis compared to what it is during the winter, I would definitely come in to get it evaluated and treated.
That's helpful. Okay, so can you comment on Enbrel? And also, in the case of someone stopping medication like Enbrel for a period of months, is it safe to restart?
Okay, so Enbrel, which is an anti-tumor necrosis factor alpha, and anti-TNF alpha blockade. So the issue with these medications is that sometimes the body can recognize them as being foreign entities. So there is this sort of concept in psoriasis literature where basically patients get treated with these biologic medications and they stop for a period of time. And they restart months down the road when they're comfortable restarting it. And the body can sometimes recognize those biologic medications as being foreign entities. And they make neutralizing antibodies that literally go out and neutralize the medications and stop its effectiveness. That's one of the reasons why sometimes when you stop a biologic and then you restart it down the road, that it doesn't work as effectively. So there's a whole slew of data and people describing these kind of things where basically medication is stopped. And then when it's restarted 6 months later or 12 months later, it's not as effective as it once was. And the question is why does that happen? Well, it's the possibility of those neutralizing antibodies playing an interfering role. But the truth is that no one will really know for certain for each individual patient. Some patients can go back on the Enbrel and have a response that's effective. And then other patients can go back on Enbrel and it can be completely ineffective. I traditionally write for within that class of medication for Humira. And what I found is that in some patients who have stopped Humira and have gone back on it 6 months or a year later, there have been a whole sort of group of patients who didn't respond the second time to the Humira restart like they did with the first set of treatments that they got. And so what happens is when they restart a TNF blocker like Humira and they don't work, I switch them to a different class. So I switch them potentially to Stelara or Cosentyx or Taltz or these other newer medications like Tremfya or Skyrizi. And usually that gets around, in my experience, around the issue of neutralizing antibodies for that set of medication. It introduces a different medication that's more effective, that's faster, and that the body doesn't have antibodies to. So that's my experience in terms of stopping and starting. It can be frustrating, but as a doctor, when I run into patients who restart a biologic and don't respond, a lot of times I switch it to a different class to get around that problem.
Makes sense. Okay, so this is a good question. I was actually curious myself. So how do you know if you have eczema or if it's psoriasis?
Okay, so eczema and psoriasis actually look different. But what I was trying to, the point that I was trying to make in the presentation is that there are conditions that sometimes are mimickers. So there are forms of eczema, like nummular dermatitis or coin-shaped eczema that occurs on the legs that sometimes can look like psoriasis, and psoriasis can sometimes look like eczema. And so, but there are certain features that distinguish them. For example, psoriasis is a very sort of sharply demarcated plaque with scaly skin. And that scaly skin is usually white, almost micaceous, silvery appearing skin. Eczema is a little bit different. Excuse me. The eczema patches are thinner. The scale is not as white and shiny. The borders are usually sort of ill-defined. So eczema looks a little bit different than psoriasis in terms of its appearance. But if there's any question about one versus the other, if you're in a situation where there's a diagnostic uncertainty, the biopsy can help introduce the certainty that you need to nail down a diagnosis so that you can get on the right medication and then get completely clear. I've had many patients who have been told for many years of their lives that they have eczema and have been treating eczema for 20 or 30 years. And then I biopsy it and it turns out to be psoriasis, and I put them on a biologic or some other treatment, and then they get completely clear for the first time in 20 or 30 years. So the nature of the diagnosis is actually really, really important to getting on the right treatment plan so that you can get completely clear.
Okay, that's helpful. With that in mind, let's actually ask the audience here. So for everyone, I'm going to launch a little poll right now. So you can see it should come up on your screen. So if you guys could all tell us a little bit, have you been diagnosed with psoriasis? And like Dr. Abraham was just saying, it depends on who's diagnosed you. So yes, you've been diagnosed by a board certified dermatologist, or maybe by another type of doctor. if you guys could start filling this out, that would be great. It'd be helpful. And then the second one of which treatments have you tried? I think it'll be interesting to see what we have here between the group. So I'll leave this up for a moment. But while people are filling this out, have you seen people come from a different type of doctor or from, different type of practice that have been told one thing and it's actually something else relating to psoriasis?
Sure. I mean, I've seen patients with recurring rashes that occur in the armpit and the groin who have been diagnosed with intratrigo or fungal infections like tinea, and have been repeatedly sort of treated with topical antifungal creams. But then actually when they were biopsied, actually had psoriasis all along. So we see a good amount. So the answer is definitely yes. But they come from other offices, family medicine practices and the like.
Okay. Well, only a few of you took the poll, but that's okay. It still shows. So it looks like half of you have been diagnosed by a board certified dermatologist, and then some of you don't have it, but you think you might. And then what have people tried? It looks like most of you have tried topical steroids. Some people those are, but it seems like not many of you have tried some of the more aggressive treatments. So I hope you were able to learn a bit today from Dr. Abraham. Mm-hmm. And he's definitely available. We are open right now for in-person visits as well as virtual consultations if you would like. So, okay, last question here. The next one is, I get psoriasis on my elbows, ear, and scalp. I use triamcinolone on my elbows and outer ear. I have clobetasol propionate for my scalp. Is there a shampoo that would work? I feel like the clobetasol is greasy. I don't use anything I feel is itchy on one side and get what appears to look like, if I don't use anything, I feel itchy on one side and I get to what appears to look like dandruff. It's uncomfortable to wear anything but a white top. Any suggestions?
Okay, there's actually a lot of stuff that you can do. So number one, triamcinolone is a great medication. Clobetasol is also a great medication. There are other things that you can introduce. Number one, you can use clobetasol as a shampoo. That's a possibility. There's also the possibility of using a medication called ketoconazole, 2%, as a shampoo and using it at least 3, 4, 5 times weekly. That's another possibility. The only thing with that medication is that sometimes if you introduce ketoconazole for lathering into the scalp and the ears for psoriasis and seborrheic dermatitis, sometimes it can interfere with hair dye. And a lot of female patients sometimes steer away from that and don't want to use it because of that reason. But there are other things that you can do for scalp psoriasis that are really effective. So some people have plaques of scalp psoriasis that are actually injected with intralesional kenalog. So that triamcinolone comes as an injection that you can inject directly into the scalp to actually get the scalp psoriasis under control. The alternative is to potentially consider actually going on Cosentyx, which is FDA approved for scalp psoriasis and can get your scalp clear, but also clear out for sure the plaque psoriasis that's on the elbows and in the ears. So you have a whole slew of options, both introducing shampoos that are different. You can introduce stronger topical steroids than triamcinolone. You can switch to clobetasol cream or ointment for your elbows. You can inject the scalp with kenalog or triamcinolone, which is an injectable steroid, or you can actually do a systemic injectable, which is the Cosentyx. So there's a ton of options that you can use to get completely clear in that situation.
Thank you so much. This is really helpful. Someone's commenting right now. Thank you so much. This is very informative. I'm changing doctors and coming to you. LOL. So I hope whoever that is, please tell Abraham you saw this webinar. But otherwise, I think that wraps up all of our questions. So if anyone else, if there's anything we can do to help, you can always email or call the office. Dr. Abraham would love to see you. He really is a phenomenal dermatologist, not just for eczema, but all types of medical dermatology and skin cancer. of course, we have a number of dermatologists, board certified dermatologists at our clinic and plastic surgeons, and most all of them are well versed in psoriasis, but we definitely have Dr. Abraham in Southampton and Dr. Steinenberg in Manhattan that focus their practices mostly on medical dermatology. So wherever you are, we hope that we've helped you. Someone else says fantastic talk. I
Thank
agree.
you.
We really appreciate your time, Dr. Abraham. And for
Thank
everyone
you.
else, thank you just so much for joining us. This talk is recorded, so you will get a copy of it this weekend if you want to share it with anyone else that you think might be able to help. And otherwise, please keep in touch with us on social media and fill out the survey after this closes down so we can get some feedback. And we look forward to seeing you guys all soon. Thank you so much, Dr. Abraham.
Thank you. Be well.
Bye.
Bye.